back to that if helpful. So, all right, Dr. Doer, I would hand it over to you. Oh, you are muted, Dr. Doer.
Okay, I'll try that again. Thank you. All right, so want to welcome all of you to this. The board is looking forward through and with the ACC to getting feedback. Most of you have submitted written information regarding the ACC proposal, and we thank you for that. Tonight is an opportunity to verbally provide feedback and input to the committee and the 3 board members in attendance. The ACC has diligently developed an excellent document from which to start. That's where we are now. The board thanks those members for their past and ongoing efforts for the benefit of us all. There are many areas in this document that are in good order, and a lot of people have commented that direction. As expected, there are some areas that have stimulated feedback from interested parties. Tonight, you'll have an opportunity to provide constructive comments or criticism of the proposal. We have a lot to cover in 90 minutes, so we ask that you make and defend your points, keeping your remarks concise and objective. This group of professionals will appreciate thoroughness and brevity. As Brittany discussed, the ACC will compile and consider your input in developing their recommendations to the board. Ultimately, after considering and balancing input, reason, and public safety, the board will adopt some form of this document. Not all will be happy. We're going to need to agree to disagree. It is the board's responsibility to make what they consider to be the best and balanced decision. With that, I'm going to and turn the meeting over to Scott, who will be running the meeting. Scott Van Dam.
Thank you, Harold. And those are really appreciated comments. Thank you for just setting the tone with that. And I can just assure you as well that I think our interest is to receive this feedback, to welcome it, to understand different viewpoints, and to take all of that, into account with ongoing, thoughtful, deliberation. I know for one that there's a lot of excitement and welcoming of the CRNAs to help us in the state of South Dakota to provide access to care, and we have all the respect and admiration for the level of care that they'll bring to our offices. At the same time, it's an opportunity for us to do that wisely and in a balanced way that makes sure that as we're providing a lot of more opportunity for anesthesia in an office-based setting, that we also do that with safety as our first priority, and that we end up figuring out together, as much with the consensus as we can, what the best path forward is for South Dakota. So I will just start with going first to the agenda item. On my spreadsheet, it's number 2, which is moderate sedation permit requirements, and start with Dr. Freed, who is asked to testify on that matter. And I believe we're asked to spend 2 minutes each, and then we'll be reminded when we approach that time.
Sure. Thank you for the introduction. Thanks for bringing the CRNAs on board. They're very, very welcome in the moderate sedation community. I have opposition to the 25 moderate sedation cases needed for moderate sedation licensure as a minimum every year. Currently, we have 0. It's been like that for years. We're bringing CRNAs on board to provide that safe environment. I believe it should be 0 going forward. 90% of the states right now are 0. And I think we make things pretty simple by following what the majority of states do. Currently, the recommendation of 25 moderate sedations, it presents anti-competitive behavior that may be subject to litigation in the future. And the 25 number is twice that of Alaska, which is the next state with the highest number of 12 per year. So I think the recommendation, is more or less, upselling for certain interests in our community, unfortunately. And I'm really glad that this conversation is recorded, so we all can go back on it, look up exactly what people are saying in a polite, non-over-speaking manner. And I think that the fact that 25 moderate sedation cases was presented in what I consider a non-transparent way, I think that really speaks volumes to where the current committee is going in barriers for moderate sedation providers in the state and for bringing CRNAs into the state to help the moderate sedation providers out. But I'm going to go back to my recommendation of doing what the majority of the states do, and that is 0 minimum cases to maintain moderate sedation licensure. And there's a lot of points that aren't, considered in this. And I'm going to say that, meaning that some providers practice 1 or 2 days a week. I practice 3 days a week. I like to do moderate sedations. We don't want to upsell our patients. We don't want to push that on our patients to meet minimum requirements. We feel that the deep sedation providers, do over 50% of their cases in deep sedation, whereas moderate providers, we try not to moderately sedate our patients. We use that as more of a feather in the cap as a last resort to complete the cases and to provide that service for our patients. And that's all I have to say.
Okay, thank you for that feedback. Can I just want to be sure that we are clear on one thing? You gave the indication that this ongoing case requirement would apply to the CRNA situation, and when you're a host provider, okay, when you're a host contracting with an independent anesthesia provider, the ongoing cases do not apply. Do you understand that?
I'm going to disagree with that point too, because 37 of
No,
the states.
I'm not asking for a disagreement. I'm clarifying that it doesn't apply. There is no ongoing case requirement for someone who has a host permit. When you're using an anesthesia provider in your office, a contracted anesthesia provider, you do not have a minimum case requirement. That is only for people that are sedating themselves, who have a moderate permit to perform anesthesia on their patients. Do you understand that?
Yeah, I understand that. It's currently 0, is it not?
No, well, currently there is a advisory opinion that indicates
Currently,
the same number, but it's not in law. You're right. It's
Currently
an
that number
advisory
is 0,
opinion that's
correct?
been in place.
Is that or is that not correct?
So currently there's an advisory opinion that states that there should be 25 cases per renewal cycle.
I understand that, but currently that number is 0 for moderate sedation permit holders in the state of South Dakota.
So
Brittany,
maybe I can clarify. Currently, there's an advisory opinion. It is not law. It is a recommendation in terms of continued practice and ensuring continued competency. So legally, there is a 0 requirement in that there is not anything defined in law. In the advisory opinion, it is a recommendation put forward for those that want to maintain that permit. So maybe that's the difference that we're speaking of here today. And I do know we have a number of folks that we need to get through, and I know Dr. Van Dam is actually going to call on people to testify.
Sure.
Perhaps if you wanted to, I know we got to get to Dr. Kevin Heyer as well.
Advisory opinion from whom?
From the Board of Dentistry.
Okay, should we move on to Dr. Heyer?
I don't have a whole lot to add. I think it's pretty much the fact that 45 states have 0 requirement. I don't like the idea of having to get to that requirement. I don't think that the quantity is going to represent any quality per se with that. Similar to every other aspect of dentistry, not familiar with any other aspect where you have a certain number of fillings and there's no other baseline of that. And like I said, we follow the rest of the nation. That's all I'll really say about that.
Okay, thank you. Dr. Gronston.
Yes, I agree with what Dr. Freed and Dr. Heyer said. I tried to put myself in the perspective of if I'm taking my 2-year-old son to a provider and they needed a certain number of any procedure, not sedation, just any procedure, to meet a quota. I just feel that's just highly unethical. I also feel that when there is a barrier, placed with, IV sedations are not cheap, and so you're requiring us to charge this to our patients. I feel like that's unethical in regard of patient finances as well. So that's all I have to say. And and especially because the vast majority of states, 0% have 25, 90% don't even have it. I feel like I don't even know why this is a topic of conversation.
Okay, thank you. Dan Graves.
Thank you.
Dr. Graves.
I echo the concern with the amount. I don't disagree that there couldn't be a minimum requirement to just stay fresh. However, like 25 might be unreachable for a lot of people. So that's all I have to say.
Okay, Dr. Croft.
Yeah, so I'm a dentist anesthesiologist. Don't want to weigh too heavily in on this. I can say that I've advised multiple boards around the nation on similar questions. And it is difficult to say, what's the right ethical and, appropriate approach. And what I have seen successfully done is an either or kind of approach where there is either a minimum amount of procedures done in a given licensing period, or an not excessive, but an additional amount of continuing education, whether that's simulation or defined as otherwise. But if there's a concern about saying we don't want to put our patients in a difficult spot or charge them or whatever, and the board really feels like there needs to be some kind of metric to make sure that people are up to par, then it can be either this minimum amount of requirements or an additional amount of a specific kind of continuing education, and either one would meet the board requirement. And that's kind of all my input is.
Okay, thank you, Dr. Croft. And Dennis Miller. Dr. Miller, are you there?
Hello, Dennis, can you hear me? Hello?
We can hear you.
Dennis, we can hear you.
Well, I have some opening comments here. Sedation is not a core competency of general dentistry. It has to be earned to the level of competency at the specialty level in order for practitioners to be able to say to their patients they are providing the same level of care as a specialist. You can't have two levels of care. There's a big difference in the practitioner that provides this service 10 times a day and one that offers it 5 times a year. This is one area that the state board flowchart on training to competence breaks down. The decision tree at levels 4, 5, and 6 has no oversight other than what is already in the rule. By removing many of the things in the current rules, there is no guideline and no oversight. In the hospital and same-day surgery setting, there are numerous committees and procedures and pathways and quality assurance measures that provide oversight. That's why you don't have a number of cases set for core competencies at the CRNA level and for any level. At the hospital, we have to show 100 cases as an oral surgeon that we performed it to competence, but they don't break it down for oral surgery in different settings. But they do use cases for colonoscopies, vaginal deliveries, stress tests, angiograms, nuclear stress readings, ultrasound readings, and the list goes on and on. In some cases, it's 100 cases of that type, but it's hovers around 25 a year. So when you are in the hospital credentialing committee, you need about 25 cases a year to maintain your core competency. If the practitioner doesn't have the required amount, then the credentialing committee is alerted and the department head reviews their practitioner, their history, and then decides if that privilege is extended for another 2 years. Now, we don't have that in dentistry. We just don't. And so there's no oversight of any sort. So a practitioner could say, well, you know, I believe I'm competent. Well, they're probably not, or they might not be not. And there's a big difference, like I said earlier, that, you know, Dr. George and I, we do about 10 cases at a minimum every day. And that's a big difference in competency from some guy who wants to do 5 cases a year. And I would pose to the committee that you need to have that monitored, you know, competence. The other thing that was brought up a little bit earlier was that we have access to care problems. Well, I looked at the CRNA map of hospitals and surgical centers, and scattered around South Dakota, there's a lot of surgical centers around. It's fairly easy to obtain privileges at these surgical centers to affect care for patients. And, you know, if you really feel strongly about a patient that needs some care and you're willing to do it for free or at a reduced price, and a lot of times these surgical centers are willing to decrease the cost on a sliding scale to these patients. So I think that current sedation holders have the privilege of providing sedation in their office because they went through the trouble of getting the education in a CODA approved program, and then they maintain that privilege with cases and continuing education. And that's different than maintaining their, it's called a mock, maintaining their certification at that point. If you don't want to go through and get the privilege, then don't dumb down the rules. I mean, at some point, we can't dumb down the rules. You just can't. This is too important a thing that we can't dumb down the rules. The unintended consequence will be if we dumb down the rules and say, well, anyone can do sedation. Well, then maybe a dental health therapist can come in, or maybe a hygienist can come in with expanded functions, and you know, they can ask the legislator to announce them or allow them to have independent practice. And the same arguments we're using right now to dumb down the rules can be used from these people. I know from past experience that nurses have worked in dental offices, and the board has an advisory opinion that the nurse functions under the Dental Practice Act as an assistant, and in that case, not under the Nursing Practice Act. So the Dental Practice Act has to have a provision for CRNAs that function under the Dental Practice Act and not under the CRNA and Nursing Practice Act. The other thing that I would like to say,
Dr. Miller,
what?
we have a number of folks, I apologize, that we're going to have to get to. So if you could wrap up your comments, we have other items, and you are more than welcome to verbalize comments during those.
3 sentences. The whole premise that CRNAs promoted in order to gain independent practice was the idea of 2 meaningful practitioners. So therefore, the dentist must hold a moderate anesthesia permit to be meaningful. If they don't have that and they don't have ongoing mock, they're not meaningful. Dentists pass the National Board and Practice Board, so the idea of a live patient demonstration is valid. There should be, in fact, a maintenance of competence requirement, just like there is for a CRNA. And I would say that perhaps we should do a SimMan simulation every year. If you have a moderate sedation permit, go and do the SimMan at the national meeting, or sorry, a regional or a state meeting, and we will maintain competency at that point. So my last thing at this point, and I've got other points, of course, because you guys know me. To obtain a sedation permit, the dentist must complete 20 cases to competence. So at what point does the skill set lapse? So you did 20 cases to competence to get your IV sedation permit. 10 years goes by. Obviously, you don't have competence anymore. So when do we figure out when that competency comes back? I would say It's a very dangerous thing. It's every year.
Thank you, Dr.
Thank
Miller.
you. I want to just clarify one thing that I think is a fairly subtle point, but keeps getting misunderstood by everyone, including Dennis. You people say that we have to have that these host dentists have to have a moderate sedation permit. That's not quite technically the way that it's structured. They have a host permit. They don't have ongoing case requirements with a host permit. And I want to distinguish the fact that there's a moderate sedation permit, and let's use that word for moderate sedation permit, and then there's a host permit, okay, which is two different things. They go through the initial training the same way. They get the same experience to get a baseline level of understanding of anesthesia, so they can be a good, consumer of anesthesia services that they choose to interact and engage with, and that they can be helpful in the anesthesia setting and maintaining an office that is well equipped, and that they can be part of an emergency response. But a host permit is different than a moderate sedation permit, and there are no ongoing case requirements for that. And at least that was the recommendation of the committee. So just let's be clear about that. And let's go on.
It's Dennis, I get rid of that, because the whole idea for CRNAs to get here was a meaningful provider. And if you get your IV sedation permit and all of a sudden you let it go and you don't do anything for a couple of years, you're not a meaningful provider.
Dennis, let me clarify one more thing, is that there are requirements to maintain the host permit. There are CE requirements, and there's office inspections, and there's emergency staff training that goes on with that. But it is not that you have to perform anesthesia yourself. Once you're a host, and you don't have to perform anesthesia, and you don't have to demonstrate your competency in performing that anesthesia going forward, and there's no ongoing case requirements, but there's educational requirements, and emergency protocol requirements, and maintaining your office and having it inspected. So that is the whole idea, and let's be clear about that so people understand and don't confuse the two things.
Yeah, so let's be clear on that a dental health therapist then could all of a sudden say, well, I passed this, and now I got a CRNA in my office.
That's an absolutely terrible point. I'm just going to throw it out there right now. Comparing us to dental therapists and hygienists is a terrible point. Absolutely disagree. All right. We need to do
that was confusing to me as well.
What the other states are doing. 90% of the other states. There's no reason for us to make up special rules that 90% of the other states are not doing. That's the point of our moderate sedation group. The points that Dennis Miller made with dental therapists and hygienists is insulting to every moderate sedation provider in the state.
I would like to
I'm going to intervene right here, and this isn't the time to have these types of discussions right now. It's the time to be clear about what the proposed rules are, and to provide feedback on those rules very specifically. And so my point of clarification was just to help people understand the difference between a moderate sedation permit and a host permit, because there's a difference, okay? Just so that it's clear in our minds. And I think we should move on to Kara McMacken. You wanted to testify on this?
Sure. Thank you, Dr. Van Dam, for the couple minutes here. I'll be brief. I've had feedback, and for decades, including the 16 years I've been a CRNA, we've been restricted with what healthcare providers we can work with. We're thrilled to have the legislation passed. We are very grateful, and we want to thank the dentists for their support. To be able to provide, our goal is to be able to provide the full spectrum of anesthesia safely, and that was the purpose of our legislation, is that access to CRNA anesthesia care. Having the additional personnel with the BLS, ACLS, PALS certified with this would be beneficial, in an emergency. Just to be clear that the other MDs, surgeons, and healthcare providers that we work with, including what was testified, is that they expect us to know and perform our area of expertise, which is anesthesia, and providing that safe anesthesia care with the appropriate resources available, just agreeing with what you said prior to this. Most providers we work with do not have detailed knowledge in anesthesia care. Moving on to the medication portion of it, in the list of the medications for moderate sedation that would not be given, I included a proposal adding dexmedetomidine or Precedex to that list. It's a commonly used drug for deep sedation, general anesthesia. It could be used for moderate sedation. However, the on-load, it takes longer to take effect, takes longer to wear off. It's just a proposal for you to take into consideration. Thank you for this time.
Thank you for those excellent comments, Kara. And Dr. Kappenman, would you take some time?
Yes. The couple things that I think the 25 is very excessive, just simply because, first off, 90% of the other states don't do it. The other thing is they keep talking, you know, Dennis was talking about competency and things like that. But that's part of the reason why we have specific CE courses for the sedation portion. So, I mean, if you don't do the CE, you're not going to maintain your license. So the thing is if you're going to require the 25, then get rid of the CE requirement, because, you know, then you're doing both at the same time. But I think it's a lot easier to keep track of the CE than it is to keep track of the number of cases that are done. And the other thing is if you get close to the end of your cycle and say, hey, I need 5 more cases. Well, here comes this 18-year-old that has a little bit of a anxiety issue. You're going to do a CE, or you're going to do a sedation for a cleaning because she's a little hyper. Well, that's absurd. So that's all I have to say.
Okay, thank you, Dr. Kaplan. I would just point out there that, you know, CE is an academic cerebral exercise, and providing anesthesia and competence is a clinical exercise, which is why I think that there's kind of a distinction. But that's some interesting good points. And Ed Lynch, Dr. Lynch.
Thank you, Scott. I'm not going to add anything because I think everything's been said. But thank you.
Well, that brings us to the end of the first item. We probably let's move on to item 3, and that's application for permits or renewal. And I don't know if that's a lot of additional testimony that would be useful, but we'll again go down the list of those that said they wanted to testify on item number 3, and that again starts with Dr. Freed.
Yep. Hi, thanks again. Item number 3. You know, when we look at the 25 minimum moderate sedation cases annually maintain a moderate sedation permit, you know, the question I have is, are CRNAs trained to the level of sedation competence as oral surgeons? You know, I think that's a question that I would like answered publicly by our colleagues, so we can make, in my opinion, the right decisions about incorporating these new rules or policies, or at least the ones that are being presented, into the dental practice when the CRNA providers come on board. I'm curious to know, like I said, if CRNAs are trained to the level of sedation competence as oral surgeons.
I think that is certainly a discussion we can take note of, and we can connect with you and with the CRNAs and perhaps provide additional information.
Okay, I have nothing to say for the application for permits other than it needs to be what the 90% of other states do. And I hold that position strongly. Thank you.
Great. I'm going to back up one moment because I neglected to give Paul Knecht, the SDDA, some time, and he, Paul, would you like to comment on the last discussion? Our executive director.
Sure thing. Yeah. Thank you, Dr. Van Dam. I just witnessed history tonight when Dr. Lynch said he didn't have anything to add. It's kind of interesting. So You know, we have submitted written comments, and so I'm not gonna, if it's okay with you, I'm not gonna verbalize those. You and the board and the committee have those and can look at them certainly. If you don't mind, I'd rather kind of just give you a little context for how we came to giving you those comments. They are the product of our Practice Act task force, and that's really a group of dedicated dentists that have been reviewing and commenting on proposed changes to the rules and to law that the board's been making, you know, probably for the past, I don't know, 6-7 years, maybe even longer than that. So they've developed a lot of expertise and experience, and that's why we rely on them to help out and provide comments back to the board, you know, for this, what I would consider initial and informal feedback that you're looking for. So just so you know where that's coming from the association's perspective. What I do want to share with you is that I really appreciate, we appreciate the board's willingness to once again have this kind of open dialogue in an informal type setting, so that together, you know, the regulators and those that are regulated can come up with the best solution for the profession and for the protection of the public. And you've had a history of doing this, and we've certainly had a history of engaging with you in these conversations, and a lot of, I think, success and good rulemaking has come out of that process. So I appreciate that, and we're going to continue to stay engaged with you all. But one of the challenges, oh, I'm sorry, am I out of time?
If you have some more to add, you can go ahead.
Okay, just quickly, and then I'll get out. We have tried to get input from our members about this, and I would tell you that I think, admittedly, it's been difficult the last few months to do that. I think that we have a lot of dentists who have an interest in the potential to use a CRNA in their practice to enhance the care that they provide for patients. I think right now their focus is just on other areas. They're focused on keeping their practice afloat, you know, keeping their employees going, taking care of patients, etc. And we've struggled, frankly, to get the kind of feedback we'd like to have from our members. And so we're going to continue to solicit that, and as we have feedback, we will certainly provide it to the board. But it seems to me like whatever we come up with, you know, for initial rules here, this is the first time dentists have had a chance to collaborate with CRNAs, and we're just going to have to be diligent about observing how this works and be ready to modify the rules on an ongoing basis as we learn more about how we work together in a collaborative fashion with them. Thank you.
Thanks, Paul. So just we're on item 3 right now. This application for permits, the renewal, and Dr. Freed, you know, gave some testimony. There's a number of other people here that said they wanted to testify. I don't know if they've already pretty much said what they want to say on this subject, but Dr. Heyer, Dr. Gronstrand, Dr. Heyer, anything new to add on this?
Not necessarily from what's been said. I would appreciate some clarification. The comment, I don't mean to misquote, but I believe it was made that we don't want to dumb down the rules. But to clarify, we're not talking about lowering the bar on anything. We're just not adding the regulations to be the #1 most stringent in the nation on the 25 cases, correct? We're not talking about a hygienist or other providers doing sedation or rolling back anything. It's just to not vote to over-regulate, correct?
Specifically, yes, you're right that right now the requirement to have 25 cases would be new in the regulation. And again, that's just for the moderate permit holders, not for the hosts. But it would be new. It's not new in concept because it's been on the books as a board advisory opinion. It's a standing advisory opinion so we would be going back on that. If we eliminated it, we'd be eliminating that as an advisory opinion as well. So in that sense, we would be no longer making that advisable. So it went from advisable to required with this set of proposals. So yeah, it's nothing new. It's an advisory opinion, but it would become a requirement. And so I assume if we decided to eliminate that or to modify it, we would be going down back, you know, we would be changing it to eliminate that recommendation. So let's, Dr. Gronston, anything to add here before we move on to a fully different item?
Hey, Dennis, I'd like to add on.
Is that Dennis?
Yeah, go on.
Dennis, I'm going to go in order. I'm going to go in order down the list. Dr. Gronston's next.
Yep.
Yes, thank you again. You know, the only thing that I would add is I don't understand how the anesthesia committee came up with this number. It seems like just a number out of the air, and especially when it's double what the current state has, I feel like I just really, if you could provide some background on this number.
Okay, then let's. So the number came from the advisory opinion that was before my time. Roger, would you like to speak to that?
And I could perhaps provide a little clarification on some of the resources that were looked at. So the advisory opinion came forward in 2017. I think in looking at that, there were a number of things. Number one, you're right. What are other states doing? Definitely, there's a minority of states that are requiring this. Looking at it from perhaps more of the medical side, where there are ongoing case requirements to maintain certain privileges, and recognizing that this is one of those areas that perhaps falls outside of the core, if you will, privileges for dentists, wanting to ensure that permit holders that were going to maintain that ability to administer were in fact continuing to administer. Our fear, based on, you know, obviously what people have perhaps seen in other states, is if you have someone with the ability to administer that is not for a long period of time and then chooses to administer again, so in an unsafe manner, there's an outcome, and certainly something that we don't want to see occur in South Dakota. So some of the resources looked at in terms of credentialing requirements for others, requirements for dentists across the United States, and then the practical side of, if you're going to do anesthesia, you know, should you do 25, obviously breaks down to, you know, approximately to a month. So I can just, for context purposes, provide perhaps that information. Certainly understand that there are varying perspectives on that number and that requirement across professions.
Dr. Van Dam, can I add a quick follow-up?
Who's this?
Dr. Gronston.
Yes.
Yes. So, Ms. Novotny, can you provide that on the board website, the past resources that was generated, the information?
So in terms of the credentialing requirements, I don't know that I would be able to post those. Those you would have to get facility by facility. I'm sorry to
interrupt. That's not what I'm saying. You said there are other cases in other states where this has been an issue. Can you provide that data?
No, I guess what I'm looking at are the bad outcomes. So those that we've seen in the news where there is a bad outcome, there's a death due to sedation provided in the dental office. I think our goal for everyone here today is to try and figure out how to safely and effectively regulate this so that dentists can continue to provide services in that safe and effective manner. So just trying to provide the resources that were looked at. Appreciate the comments relative to the specific number, and thank you.
So I'm sorry, one more follow-up and I'll be quiet. But so you cannot provide information on past cases in other states where the 25 mandate was not followed and there's bad outcomes?
Oh, no, I was speaking to the bad outcomes generally.
Generally speaking.
Mm-hmm.
Okay,
yes,
thank you so much.
I appreciate that there are varying perspectives in terms of should folks have these cases on an ongoing basis. Again, probably speaking to the broader goal, which played into that discussion back in 2017 and we have today, which is how do we safely and appropriately do this? We want to ensure that our dentists are doing it safely and appropriately, and that there isn't a bad outcome that would impact the ability to do that going forward.
Okay.
Yes, thank you.
If there's anything meaningful on this specific topic to add, if anyone wants to, talk to this, we actually moved on to agenda item 3, which was technically permit renewal. Would anyone like to speak to that specifically, or should we move on to the moderate sedation course requirements?
God, I wouldn't mind just addressing something real quick. This is Dr. Graves. I have a business partner who's in Winter, South Dakota, and it's a rural area. He provides the service to patients who have limited access to care. However, it's not an unlimited patient base, so it's not like he has people to draw from all the time, but it's a service he's adding. He's doing it consistently. However, I don't know how many he's doing a year. He's probably doing more than 25. However, in a state like South Dakota, we have so many rural areas that there are providers providing services that improve the quality and the access of dentistry to patients there. And I feel like it's one of those things that really shuts a big door on some of those areas if we put a number that's perhaps unreachable. So also, if there is a number that's required, I think it shouldn't be an annual thing. It should be more of a every time you renew your permit, not necessarily every year you're going to meet 25. If you have to have it within your renewal period, I think that's a little more reasonable than just every year you got to hit 25. And that's all I have to say.
Okay, thank you. I just think it would be interesting to hear from those providers who are present. Is there any provider present who would anticipate doing less than 10 moderate sedations in a year if you held that permit? Is there anyone who would have any degree of doubt that they would perform 10 moderate sedation procedures in a year? I mean, and just to add one more thing, if the idea that something is not part of a core competency, I think it's relevant, because it's something extra that you've added into your repertoire. It's something extra that you've been trained and been certified to do to competence. And if I'm going to go get a procedure done, you name it, a knee replaced or a hip or whatever it is, I am interested if that person is proficient in practice. I know that if I took a year off of practice and came back to I would be able to do a lot of the things I used to be able to do, but one of the things I'd be very concerned about is my ability to safely provide the kind of anesthesia that I do right now. Things change, things move. But anyway, I'm just curious with some feedback from you, just honestly, openly. Do you think if you did, or if you took your kid to someone and you let them sedate your kid, and there was a little emergency happened, and there were some issues, and afterwards you were getting questioned by the family, and they said, well, how often do you do this? How often do you sedate people? And you're like, oh, well, I did 2 last year. That just to me is a concern with anesthesia specifically, and it's why anesthesia in hospitals has anesthesiologists have ongoing case requirements. If they don't meet those, then they're not considered, or at least they have to be reviewed, like Dennis said, in a hospital setting, to say, like, wait a minute, you're an anesthesia provider. You don't just dabble in this. You're an anesthesia provider at some level. there has to be some ongoing proficiency and practice involved with providing care. That's just my thought, my personal thought. Whether 25 is too much, but here we're rolling something out throughout the whole state of South Dakota. Do you want kids in the state of South Dakota getting care from people that hardly practice anesthesia and where their teams aren't familiar with and just that there's a comfort level from repetition at some level of doing anesthesia.
Sure.
So that's
can
just
I answer
my
that question for you? I'll answer that question for you. We can't sedate anybody under a certain age, number one. So we wouldn't be able to sedate kids. Number two, we don't do deep sedations like the anesthesiologist.
I'm talking about a 13-year-old.
We haven't had any issues with the moderate sedations that we do or complaints, and people seem to be pretty confident in our ability to be able to provide the service. So unless there's a negative outcome in South Dakota and moderate sedation providers that I don't know about, I would 100% agree with your statements, but I haven't been presented with a bad outcome for moderate sedation providers in South Dakota.
I bristle a little bit at saying about I haven't had bad outcomes. Outcomes are statistical realities, and unless you're a statistical anomaly, you have laryngospasms and you have all sorts of things, and unless you're a statistical anomaly, there will be 3 in a million deaths from
sure.
this.
I'm going to request that negative outcome from if there is one from all the moderate sedation providers in South Dakota. I'm going to request that statistical outcome, and I want it to be presented to me when you get that information. I want to know exactly.
That's not studied. Happened. That's not studied. Anyway, that was just my observation, and I'm actually getting us off track, and we need to keep going.
I may just note that thankfully in South Dakota, we have not had any bad outcomes. And again, I think that's the goal of everyone here today. Let's help ensure that we have a framework in place that keeps everyone safe in South Dakota going forward as well. So for that, we appreciate all of the feedback and certainly understand that which we've seen in other states, we don't want to see here, unfortunately. But
this is Dr. Croft. I have some input here if it's allowable that may kind of bridge the gap here, but let me know if it would be appropriate at this time.
Let's go ahead and hear it.
So what I hear is two sides of the story: the moderate sedation providers who are opposed to this idea, and then people on the other side from various groups saying, well, in order to maintain safety, here's how we do it. And I think maybe if we took a step back and said, if maintaining safety is the goal, how do we obtain that? So if doing a certain number of cases a year is the right way to obtain that, then we're talking the right conversation here. But I think what we're doing is conflating sedation with the ability to manage emergencies, and there's definitely overlap. But there are other ways to make sure that people are competent. South Dakota requires ACLS certification. And if we're not relying on ACLS certification, why is it recognized and required? Yeah. And if we're saying, well, ACLS helps, but it's not required, then why is it, why are we leaning on it so much? The other one, again, I go back to maybe the suggestion here the board would maybe want to take up at a later date, is that if there is a situation where genuinely a well-intending provider is unable to provide the minimum number of case requirements, that there's an alternative pathway to demonstrate safety, right? Again, so that comes down to maybe they have to take not a remediation, but a review course in sedation, or they would have to take some kind of simulation CE or something along those lines to demonstrate, yes, I didn't do the minimum competency, but I'm not doing this so infrequently that I can't recommend this safely to my patients. And so maybe that's something to be taken up later, but I do think that there are other ways of demonstrating competency besides minimum case requirements, and I'll kind of leave.
And I think those are some very constructive comments, and I think that can all be and should be taken into consideration. I would add that having a real meaningful conversation right now, you bring up ACLS. Well, ACLS is not the way to assure minimizing complications. ACLS is only when crap hits the fan that we can have a reasonably coordinated response to a cardiac event, you name it, you know, whatever the algorithms are. So that is different. That's not gonna. We're talking about preventing complications of anesthesia. You know, with good practice, and that comes with practice. And there's other ways, you know, with simulation training and things, but I think this is a good discussion. And by no means is this, in my mind, anything about limiting access or creating big hurdles. It's about making sure that the people in our state that are providing anesthesia are comfortable riding that bike, you know, and are good on their, you know, have good balance, and have some degree of ongoing you know, practice, which is where you get better at things, and where you get comfortable, and where your team gets comfortable with you. And so you know, these are good discussions. I think we can move on though to the item number 4, which is the actual moderate sedation course requirements. And let me just explain a little bit why this would be tightening up on the number of courses that we allow. It is a real headache that I only discovered as I got involved here in having to approve courses on an annual basis. That we don't have a way of vetting these courses. You only have paper. You can have anyone submit a course from all around the country that meets the requirements on paper, and you have no idea who the instructors are. You have no idea what the facility is. It could be on a cruise ship. It's just a nightmare, frankly. And I hear things and I know things about some courses that are not appropriate, where they say they do things one way, but it's just kind of a crappy course. They're not really getting the individual patient experiences that they should be. I've heard a lot on the ground. I was talking today with, getting information back and forth from someone who was commenting on this, who knows, who's on the inside. And there are courses out there that you would not want people taking to be deemed competent in anesthesia. And how do you as a board make sure that you are finding out which courses are meeting some pretty good criteria? And so we'd like to go to a system where we have these courses be ones that are affiliated with a CODA accredited dental school, just so that you have some institution vetting or putting their name on a course. You know, when you get trained to be a dentist, you know, your dental school is giving you their stamp of approval, if you will, and plus there's a formal board certification process that even takes the dental school out of the equation later to some degree. You know, but when you go to a sedation course, there is nothing like that. And it's a board like ours is just stuck with seeing some papers you request, and they just copy and they all send the same paper back that says, yeah, we meet your requirements. What does that mean? And so I just think with that introduction, I would just open this next item to discussion about, you know, how do we in the state of South Dakota have some reasonable way of vetting the fact that the initial training to do good sedation is on par with some standards of any degree. And so let's open the conversation to that. And we would start with Dr. Freed.
Dr. Van Dam, if you don't mind, I just want to ask, I'm getting some feedback. If everybody who is on the phone could mute your lines, everyone on video we can see and we have muted. Thank you. Sorry. Go ahead, Dr. Freed.
Thank you. I'll be quick on this. You know, I'm glad this conversation is recorded. I think it's very, very important. And I think it's important to actually say which courses those are. You can provide any insight on which courses that you've heard about. That'd be fantastic. We're very curious to know which courses that have been labeled as bad moderate sedation courses or bad CE courses. I've heard through the grapevine that the Puerto Rico Maxi course has been getting a lot of heat through the ACC, and I've got some things to say about that. But if you could provide an example of the courses that you've heard.
I'm actually going to ask. I'm going to ask Dr. Crossland to share just a little bit of feedback on this topic.
Sure.
Dr. Crossland, we can't hear you.
Okay, Crossland.
Okay, well, I guess, again, South Dakota may be opening itself up to anti-competitive litigation based on, the decisions made by the board and moderate sedation training programs. I think that, if there's any issues with the Puerto Rico Maxi course, which is taught by Daniel Becker, I think if there were things said in the past, now's the time to say it so we can squash it and move forward with this. That's the only comment I have regarding moderate sedation course requirements. And I agree, there needs to be accredited programs, and the Maxi course is part of the Puerto Rico program. And again, it's taught by Daniel Becker, and I heard there were gripes about that behind the scenes. And I think it's a little more important to be face-to-face and discuss these things in person rather than complaining behind the scenes. So if anyone has anything to say about that, I'd like to hear it now.
Dr. Freed, I may just make 2 clarifying points and correct me if I'm wrong. I believe the Puerto Rico course is affiliated with the Coda Accredited Dental School, and maybe Lisa could help confirm that. And number 2, it is an approved course. So for what it's worth, I understand that there is always a discussion surrounding every course, and appreciate your comments. But did want to clarify those 2 points. If it's affiliated with Coda, it would continue to be approved to fit that criteria.
Oh, okay. Thank you, Brittany. I guess we won't have to discuss that then. I appreciate it.
And I know Lisa's looking at moderate courses. I believe that Dr. Van Dam may have stepped away, and so we can certainly continue on. So Dr. Freed, Dr. Heyer next.
I think we can keep moving. I don't have anything to add.
Okay. Dr. Gronston?
I just pretty much, we all read what Dr. Croft had mentioned, and I'm just in full agreement with his perspective on this. So I would just say, I guess that's all I have to say.
Thank you. Dr. Graves?
I'm not much to add to that. Just that courses have to be legit. So they're not teaching you to do it properly. They shouldn't be a proof course. But I don't think you should limit it so that.
Okay, Dr. Graves, your audio is not coming through very well.
It's okay.
Dr. Farnham? Okay, Dr. Croft?
Yeah, so the one comment here is that I have reviewed sedation courses before. I've written content for them. I'm not unfamiliar with how things are done in good courses and not so great courses. My comment on this basically is that, first of all, South Dakota has compared to every other state, I've seen one of the most arduous review and approval processes, which I think was mentioned before, and I think it's wise to kind of step away from that for a number of reasons. But the hard part then becomes, how do you vet courses? The approach that's recommended here seems logical, but I have seen, and I know for example, a course that's provided out there where there was some scuttlebutt that states might start doing this, requiring affiliation with coded accreditation. And so they went and made a quote unquote affiliation with a CODA accredited institution that has no residencies that teach any kind of sedation or general anesthesia of any notable degree. But they were able to get an agreement in place, and there's co-branding and everything, and now they're affiliated, and nothing changed with the content that was provided or the patients that were treated. And so my input here for the board to kind of take back and review is, while you do need to find a way to make sure that courses that are provided are legitimate, having affiliation with a code accredited institution, it ends up being another tax code law equivalent where people just around it.
Okay. I mean, and
so if there's a way to vet by saying have.
So, Dr.
If you need to find a way to say, it needs a minimum number of faculties or whatever else, that some approach needs to be there, but affiliation with CODA accreditation is just another hoop that people can jump through and then continue doing what they're doing.
I think that's really interesting and good feedback. I just know that there has to be a way to vet courses, and the way that it's presently done is difficult. And either you just take everything for face value, or you find some ways to either audit the courses. Maybe the board members need to take turn auditing courses in person to understand what is being taught and how, and try to assess the quality of those things. But it's a difficult part of managing and regulating anesthesia, this particular thing. So if there's any more comments on that.
Yeah, briefly. My response is to say auditing courses is adding another level of complexity. I'd recommend against that for a number of reasons. But most states will do one of two things. They will either vet the courses by saying, when we come and inspect a provider, that's where we vet if they're competent or not. And if that's not sufficient, or if that doesn't work for that state, they vet the course beforehand somehow, and then they don't have to do an inspection afterward. And South Dakota is kind of looking at doing both here. So again, from my experience, I don't know of another state that I've been involved with that has as involved a process to get a course approved, or to have a dentist want to take a course and then get certified. And I just don't know that I think it's wise to relook at this, because I don't know that South Dakota has better numbers than any other state out there that has a different system. I can give you some input. I think this might not be the right forum for it if you're interested, but there's a number of ways of doing it. But I do think that the current process, and also some of the proposals here, may be attempting to get a particular ends here. That would be a good thing, but I don't know that the means are the most advisable. And that's, again, maybe a conversation we had at a different time.
Dennis, it's your turn to comment if you had any comment on this item.
Oh, no items so far.
Okay, Dr. Kappeman?
Nothing to add to this.
Okay, Paul?
Nothing else from us. Thank you.
Okay. As we close this one out, Dr. Freed, you had the most strong response to this. What would your recommendation be?
My recommendations are follow recommendations of Dr. Croft. He seems to be very experienced with other states. in this process. You said that this our moderate sedation process is very regulated already. Again, my opinion is to do what 90% of the other states are doing. But if our colleagues want to add additional recommendations, I think Dr. Croft is an enormous resource, and that's apparent in this conversation that we've had. I think use his advice, talk to him on the side, and go from there.
Okay, let's move
Dr.
on.
Van Dam, can I have one follow-up?
Go ahead.
Okay, so just so it's recorded, I just looked at the moderate sedation permit courses that are approved, and the Puerto Rico Maxi course is not on that list.
Thank you.
Thank you.
We will, let me look into it as you speak.
Thank you.
Thank you, ma'am.
Okay, the next item, number 5, is employing or contracting with licensed anesthesia provider that provides general anesthesia, deep sedation, or moderate sedation in the dental office. And that might be a lot of duplication of what we've already heard testimony on, but we can go down through the list again. Dr. Freed, anything to add there?
No, I'm just going to repeat. I recommend removing the advisory committee's 25 minimum sedations for moderate sedation licensure per year, and going forward with the other 90% of the states do. Thank you.
Okay, Dr. Freed, can I just ask you, do you find any value in any number, any requirement at all?
0 is a really good number. I feel like it's working pretty well in the past several years. I know providers that have had their sedation licenses for decades and have had 0 issues. Again, I want to go with what 90% of the states do. I feel that is the right choice for moderate sedations in our current environment. I feel with CRNAs coming into our marketplace, I feel a lot of this stuff has been made for anti-competitive and conflicts of interest reasons, and I can expand on that later, but this is the time for it.
Yeah, I think that's very disingenuous of you, myself, but that's okay.
Okay.
Had nothing. The discussions never had any bearing on that. These discussions were balanced discussions about safety, and your concern about limiting practice and such is unwarranted. My opinion.
Well, should we discuss the revenue that comes into deep sedation providers' offices and the profit margin on it? Do we need to have that discussion now?
You're welcome to express your opinion on that.
My opinion? Okay. Well, that's another discussion we can have later, but we'll stick to the minimum sedation requirements at this meeting because that's the agenda. Thank you.
Okay. Kevin Heyer. Dr. Heyer.
Yep, I have nothing to add on this one.
Dr. Gronston.
That's all this is.
No, sir, I'm good. Thank you.
All right, Dr. Graves.
No comment.
All right. Does anyone else down the list want to talk about this? Dennis?
Yep. I support the rule. The whole idea that CRNAs can come into the dental office was predicated on a second meaningful provider. If the dentist does not hold at least a moderate sedation permit, they are not a meaningful provider, and that abrogates the whole intent of bringing the CRNA into the office. I would prefer the CRNA still functions on the auspices of a supervising anesthesiologist, and that is why the rule that the CRNA must have privileges in the South Dakota same-day surgery unit or hospital must stay in force. It's our quality control measure and our only avenue to make sure that cases are reviewed by the dentist and the CRNA are in fact reviewed by an anesthesiologist.
Okay, thank you, Dr. Miller.
Scott?
Yes, who's speaking? Yep.
Yeah, with respect to this, I guess I do have some comments, and I can't stay quiet forever, Paul. The discussion with bringing in the CRNAs is that the dentist that's hosting needs to have moderate sedation permit.
No, that's not true. They get the initial training and they do not maintain a permit, and they don't do ongoing cases.
They have to go through all the cases to learn it. They have to go through all the licensing. They have to go through all of the inspections, have everything and all the equipment there, those things. But my point here is that if I choose to do moderate sedation and be a moderate sedation provider myself, I am the only moderate sedation provider in my office. I have assistants that have training to help monitor, et cetera. But I'm the only one in that office that is licensed to do the moderate sedation. Now, when I bring in a CRNA, you're saying I need to have 2 people that have that level of training. And I'm going to say a license, because you have to have a license. It may be slightly different, but you don't have to do the cases, but you still have to have everything else done at some point in some way. Why is it necessary to have 2 providers when the CRNA comes in, but when I'm a moderate sedation provider by myself, I don't have to have a second person there? That makes no sense. It's overkill. The point behind bringing in the CRNAs is to make it easier for dental offices to bring someone in, be able to safely do sedations, and be able to get it done in a more easy way. This is not easier. It's just as hard as doing the moderate sedations yourself, except that you don't have the case requirements. Now, that said, I mean, a lot of you know that I did hospital dentistry for a lot of years. I worked with CRNAs, and so have you guys. I know you have, Scott. And I found all of those CRNAs to be very good and very competent. And I would have no problems with them coming into my office and working on my child or my family, even if I was not a moderate sedation holder, because they were all very excellent and professional. I don't see why we need to have a second moderate sedation license in the office when it's not required if I'm doing it myself. That's all. Thank you.
Does anyone want to speak specifically to Dr. Lynch's comments?
I'll say it. I've been in the operating room, I've been in the same-day surgery unit, and the CRNA is completely incapable of administering anesthesia for a patient who has an advanced problematic airway when there's an anesthesiologist present. And those are the problems that we are trying to prevent.
Dennis, can you repeat that for us, please?
I disagree with you completely. You know, we should have certain things in place where the CRNA cannot intubate people. They cannot. If you have your office and you're going to administer anesthesia, you have a glide scope available. You have a fiber optic scope to take care of an anteriorly placed trachea. No, you do not. And so I would posit that no, you are not available to provide general anesthesia permits to a CRNA. The CRNAs are used to going into same-day surgery units that are JACO and ACCC accredited, and they are used to having the equipment and the facility available for them to rescue people and a backup. And a lot of general dentists that are having moderate sedation permits are not meaningful providers. Not meaningful providers.
Okay, Dennis.
Anyone, anywhere.
So we're gonna
Oh, please let Dennis talk. Please let him talk.
Yeah. So
finish
my
your
problem is
finish your thought.
for the few people that you may put in your office, and you may decide that, oh, okay, yeah, we will have an anesthesia permit for them, and we will knock them out. Well, we have no backup for them. We have backup for moderate sedation. We do not have backup for general anesthesia. We do not have backup for securing the airway. We don't have it. Don't have it. And this is the problem we have.
So just to bring us back a little bit, Dennis, I personally value the training and the expertise and the ability of CRNAs to use their guidelines and criteria and their training very well to select patients and to respond well to emergency situations. They're very, very well trained. They're on par with the best anesthesia training that's out there and that you or I have received.
No,
that's not the issue. That I just want to share something. The issue is, and what I want to highlight,
to a bunch of anesthesia trainers, and none of them, zero, have had any training in pediatrics. None, zero.
So, but the point I'm trying to make is a different one, though. My perspective on having a host permit is that I do believe, and I think that the discussion amongst the committee, which was a very good discussion, is mainly focuses on the fact that when an anesthesia provider, whether that's a dental anesthesiologist or an MD anesthesiologist or a CRNA, comes into your office in rural South Dakota, they're at a structural disadvantage to what they have in a hospital setting. It's not about their skill or their training, their ability to manage things. It's about the fact that we're turning all these dental offices into operatories for anesthesia suites, and there has to be a mechanism for the board to determine that the sites are appropriate, that there's a team model of anesthesia care, which is the dental model for anesthesia, providing anesthesia, is a team model of anesthesia, where there are trained assistants and teams that have training together and that do emergency response protocols, and where there's a baseline of knowledge. And when an anesthesiologist, whether it's an MD anesthesiologist or it doesn't matter how good your training is, when you come in to just provide anesthesia in an ambulatory setting that is not a JACO approved center, you're at a disadvantage structurally, and that's where problems occur. And so the ability to have some oversight as a board into those facilities and into the team anesthesia model that's being practiced in that setting is really where the heart of this is at, and where the committee was putting forward this recommendation, not second guessing the judgment or the skill or the ability of the CRNAs to do their job safely. It's to create parity between the different settings where these people are going to come in to provide anesthesia. It's to make sure that the board has access through that permit, through that host permit, to come in and to be sure that dentist is part of a meaningful team of, and that setting is a setting where anesthesia can be provided safely. So I would kind of, you're making some other points there about training and competency, whereas the focus should be, in my opinion, on the facility and the team anesthesia care that is provided in dental settings all across the state now.
Well, then,
okay,
exactly as you say, then the team and the procedures and the amount of training and the amount of equipment that's available for other people should be equivalent to a same-day surgery setting. Exactly. Perfect. Wonderful. We all agree.
But just so that it's clear that the point of us having a host permit is that the board can help to make sure that there is team anesthesia occurring in that setting, and that there's meaningful understanding and respect for what's happening in that environment, and that the dentist is a part of it, a meaningful part of it, someone who has some basic level of knowledge to turn their office, a dental office in South Dakota, where the dental reputation is on the line, and where we as a board are basically on the line for safety, and you know, when something happens, that we can come back and say, look at this in South Dakota. You know, when we turn a dental office into a anesthesia suite, we do that with some soberness and some understanding on the part of the host dentist, and some ability to be a consumer of anesthesia services that are provided through that CRNA, that they're better equipped to help screen those patients and set up those patients for surgery, and so that the CRNA can do their job better, so that dentist is a collaborator in anesthesia with them.
What it is that the dentist should be a meaningful provider. So they should be able to assist in intubation.
No, I disagree. I disagree, because dentists, then you're missing the point. They don't have to be able to intubate with a CRNA there. CRNAs can intubate.
I disagree with you, my friend. It's like whenever we get an intubation in the hospital, we have an anesthesiologist and the CRNA. There are two meaningful providers. So
I'm just concerned, Dennis, but by going that direction with your argument, we're missing the bigger point. That's the important point, and the point that I hope that people take away from our discussion tonight. It's not to denigrate the quality of the services that CRNAs provide. It's to make sure that that's a setting that's on par with what they can expect in other places, and that we are collaborating meaningfully with them. You don't have to be able to intubate a patient as a dentist who has a host permit. I disagree.
You can actually intubate a patient, and the dentist has no clue what they're doing, and you have no meaningful provider. And that
who just said that? I'm sorry, who just said that? Will you say who just said that? That the dentist doesn't know what they're doing? Can you please say your name?
Dennis Miller. You have no meaningful provider for intubation and securing the airway.
Brittany, I don't think this discussion is productive. Can we move on to the next point, please?
Yes, we are going to now.
This is Jerem Heaton, representative from the ASDA. I would like to make a comment here when you got a chance.
Let's give you some time.
I personally have, performed over 12,000 general anesthetics in an office in rural Texas. We go in every day and convert the office to an operating room suite. And yes, we intubate, we bring anesthesia machines, we bring assistants and independent licensed providers with us, such as a nurse. We do it very competently, and so it can be done with a separate licensed provider and a competent anesthesiologist. So I mean, it's being done in other states. It can be done if you bring in other providers. I'm currently one. I mean, my question there is, this requires the dentist to be a moderate host, I'm assuming, and that the anesthesiologist in there has to have a host. It can be done with assistants they bring with them, with nurses they can bring with them. Competent anesthesia providers in the dental office can be very safe.
And thank you for that feedback. I trust, and I have a lot of faith in the ability of dental anesthesiologists and CRNAs to bring in excellent anesthesia services to our offices. My presentation there was just so that it's not misunderstood about what the committee felt and what a lot of good deliberation was on this subject, and that it's my opinion that if we as a state could find a way to make sure that when we bring in those services and contract with those services, that we partner with that individual with some knowledge and with some sober recognition of the risks that we're introducing into our office, without being scared of it, without being paralyzed by fear or anything, but by being soberly aware of the fact that we're now providing those services in our dental office, and to have the dentist be aware and familiar based on some initial good training, and to be able to help screen and select those patients, and even have some critical feedback, for the services that are being provided in their offices by these very competent providers. And also when stuff hits the fan, to be a competent additional resource. When someone's coding in your office or has an airway emergency, your patient, to be a meaningful help at that time.
Can you tell me currently in the oral maxillofacial surgery offices, do they have 2 independent providers there? Do you know that?
No, we do not. We have 2 trained assistants with us, and a model that is unique and is coming under intense scrutiny.
Right.
And
Right.
Frank, let's not have that discussion. I'm going to tell you something about that. Our model is actually under fire.
Can an anesthesia provider bring 2 assistants with him and have the same team model that would be allowed in this board regulation?
Now that's starting to become a meaningful conversation, and I'm starting to get that's yes. I think there's possibilities there, and what we've proposed is not the only way forward. But to have a team model of anesthesia, preferably where the host dentist is involved, to me makes common sense. And
well, I would disagree to say, when I'm doing it in the offices, and what my company's done 50,000, we have a person with us who's probably more competent than the moderate trained host that's with us every day, that does it just like your dentist.
Great. But my point is that you appreciate that model, that team model.
Right. The
you
team model.
appreciate that team model. That model helps you. Okay.
But then in this case, we don't allow the anesthesia provider to come in to a dentist's office with a team here without the dentist being a provider, right? Without being a host. So that limits the practice of a dentist anesthesiologist.
So these are good discussions. There's different models how you could create a team environment, and but you have to inspect the facility. You have to create, and who's better to create the facility that's appropriate and outfitted and is ready to do this than someone who's had some training, the owner of that practice. Is it too much to ask that person, go through the initial experience and training? So that's just my opinion, and it might be that we come to a totally different solution after hearing all this feedback. But I personally won't get behind anything myself that doesn't involve reasonable oversight and inspection and a team approach to anesthesia. I am very soberly aware of the risks I incur every day, and I have a team of trained people, and the people that are with me are trained monitors, and there's 2 of them in the room with me. And you can argue that they're not what they should be, and actually the ASA is arguing that very strongly at this moment. So my model of practice may change in the future.
Dr. Van Dam, will you please let the other provider talk? Will you let him speak his point, please?
I'm just, my point with facilities is if you're providing anesthesia in facilities every day, facilities general dentistry using local anesthesia on patients. Are we going to go through every dental office and say, hey, you can't provide dentistry there because you can't get you know, I mean, we have people die of local all the time, but you know, I can take two
That's a
providers.
whole level of risk.
Right, and I can be very competent in a facility that I'm providing anesthesia and with the team model that I bring. So here, I you know, making the host person have a moderate is actually is not an increase in the care of the patients of South Dakota, in my opinion. Especially when the model can bring in, you know, a provider. Let's say I bring a nurse. I have nurses with me. Sometimes I have EMS people with me. So, you know, there's ways you can make it not so. I mean, in this particular, making the dentist a moderate sedation. When I go in, I don't need the dentist at all. I intubate, you know, do all that with my team, and then the dentist takes over and they do their dentistry. We're talking 50,000 cases. I mean, it's not like I haven't done it or haven't seen it. And from the ASA, you know, from the ASDA, we're just saying, hey, we're going to comment on things that we feel that are difficult for a dentist anesthesiologist to come in, because that limits our practice in that model. In that model. Now, facility, I think it's important for the trained provider to understand what facility is in. But I don't see that different in a dental office. We are providing care for patients, and patients can have complications no matter what facility they're in. So we can't go through and say, hey, you know, I've seen EMS people take people off of burning buildings and out of burning cars. I mean, we can get people out of the office, but yeah, we got to leave that to the providers that have provided the anesthesia care.
Okay.
So
That's good information and feedback, and I think there's been very good discussion. I don't think we have a lot of other items really to talk about tonight. The last one, item 7, was.
I do. This is Kara.
Scott, this is Brent Hendrickson. Can I make a comment?
Yes, please.
I haven't spoken up tonight. It seems like there's an echo going on, but hopefully you can hear me.
If there's anyone listening that happens to be close to another person listening, yes, there is echo, and we have muted everybody that we can mute. So if two people happen to be in an office or located close to each other, please do all you can to shut down one of the mics.
I wanted to let everyone know I appreciate everyone's comments. It's been a learning experience for me tonight. I do a couple comments. I do over 1,000 intravenous deep sedation or general anesthetic procedures every year. I'm not sure how the 25 moderate sedation cases requirement really came up. It probably was debated. Some number came up. I'm not stuck on that number. It's not real important to me, maybe, that it has to be 25. Maybe it doesn't have to be a number. Maybe there's other possibilities with that. What I can say, statistics are important. You don't ever want to say, okay, maybe we're going to have a bad outcome. Maybe there'll be a bad outcome in my clinic tomorrow. I don't know. I'm certainly confident in my abilities, but you never know what's going to happen. And so to say, well, there hasn't been any bad outcomes, can you show me that? And then just because the answer is no, you don't just do something. There's a level of maturity. There would never be, if a moderate sedation permit had a bad outcome or a death in a clinic, I can certainly speak for myself, it would never be, I told you so. Second of all, decisions and opinions that I come up with have absolutely zero to do with turf battles, competition, or anything like that. There needs to be a level of maturity when we speak about this. I appreciate Dr. Heaton's information. I find it commendable that he brings trained assistants with him to his facilities. That's a different approach than what CRNAs likely do? I'm not sure. But I need to ask that question. I want to know, are CRNAs planning to go by themselves into the clinic without anyone else trained with them? Any other nurses or assistants? That would be a question I have. It's a total different situation when Dr. Heaton has trained personnel with him, because he uses a team model approach with his anesthesia. In terms of Dr. Lynch's discussion earlier, certainly appreciate it. Now, it's different. You say, well, it's a redundancy to have 2 people trained. It's not when you go up to a deep sedation or a general anesthetic procedure. Nurse practitioners, nurse anesthetists that come into a clinic will likely perform more than a simple moderate sedation. So they're not being redundant and just doing a moderate sedation with another moderate sedation provider. They're doing a deep sedation or a general anesthetic procedure with a moderate sedation or post-permit dentist. So that's a total different example. That's all I have to say for now.
Hey, Brent, can I add on to that?
Actually, since you had a specific question about the CRNA practice, that's a good transition anyway to Kara. Kara, would you provide some feedback?
Thank you, Dr. Van Dam. I have worked with Dr. Lynch and Dr. Van Dam doing pediatric dentistry. I've done adult anesthesia for these. I gotta turn down my speaker. It's really echoey. Okay, so I have done a lot of pediatric and adult anesthesia for dentistry. We would be happy to provide the education and the clinical requirements for CRNAs to even graduate from school for Dr. Miller. I personally, in 16 years, have worked in numerous facilities: Watertown, Mitchell Rapids City, Spearfish. I have worked in non-JACO facilities: Deadwood, Sturgis, Wessington Springs, Platt. I currently am in Spearfish. These facilities that we are working at, when I go to do EGDs and colonoscopies in Wessington Springs, well, before their hospital had the tornado, Platt, we go to Sturgis. We're going to facilities that it is the CRNA providing the anesthesia care and the healthcare provider, if it's a surgeon, an endoscopist, etc. The Endo Center does the same model with a GI doctor and a CRNA, and they are doing scopes on patients that have various different comorbidities, they could have potential difficult airways. As a CRNA, I have done open hearts, gunshot wounds. In a non-JACO facility, I did a ruptured spleen, and it was me and the surgeons. So we are completely competent of managing difficult airways. We do bariatrics with patients that are 6'4" and over 400 pounds. We are used to intubating patients with difficult airways and are very competent in what we are doing. And so with that, I hope that kind of gives you a picture of, we go in and we can do anesthesia on anybody in any facility, and someone such as myself with the experience I have would be completely qualified to come into the dentist's office and provide that anesthesia care for the dentist. And my understanding is that there is a requirement for people to have some ACLS, BLS, and PALS based off of the age group of population, so that if things did get bad and we needed assistance with an emergency situation, we would have that. We don't need another person there to help us intubate patients. We do it every day, all the time, and are very skilled. So moving on, did that answer the question? I do have one other comment.
Yes, go ahead.
Okay, so I want to address the comment on ensuring that licensed anesthesia providers hold anesthesia privileges at a licensed ambulatory surgery center or licensed hospital. First of all, on behalf of the South Dakota Association of Nurse Anesthetists, we really feel this rule is limiting to the population of the CRNA resources for the dentists, as well as it's limiting the employment options for CRNAs. And so it's limiting both the dentists and CRNAs. And with that, we would like to propose for that to be deleted and find other facility privileging options. We are not opposed to be credentialed or have that facility privilege, but what I have found is that none of the surrounding states surrounding South Dakota requires CRNAs or physician anesthesiologists to have facility ASC or hospital privileges to provide sedation or anesthesia in a dental office. So every state surrounding South Dakota right now does not require that. And so we would be happy with elimination of that, but in commenting about that, you would still want to make sure that they would be licensed, et cetera, which I know you have addressed in the line above that. So thank you for the time to speak.
If I could jump in and say I agree here. It's the requirement. Oh, I'm sorry. This is Kevin Croft. I can wait if I'm out of turn here. I apologize.
Just continue, please.
Okay. Yeah. So the requirement here to have someone be licensed at an ambulatory center or a hospital, to me, it seems somewhat redundant. If they're licensed, if they're in good standing with the board, if the dental board has vetted them in one way or the other, to have a private organization like a surgical center accrediting or giving someone privileges isn't really something that validates their ability to practice to a certain level of care. It is also somewhat restrictive to for example, a dentist anesthesiologist. I do have privileges at a level 1 trauma center and locations like that. So it's not an issue. This is not a personal issue, but I can tell you that around the nation, there are some places where it's very difficult for dentist anesthesiologists to obtain those because of political reasons, and so that becomes problematic there. So that's just some perspective that I've seen around the nation.
Yeah, and that's valuable information. And what Kara presented also, I think we had pretty limited discussion about this particular item. And since that recommendation came forward, I think we've learned more too about what it requires, what the requirements are for, ongoing, licensure of CRNAs, and we haven't been together with the committee to review, what that means based on that pretty compelling feedback. And so there'll be more discussion. And I think overall, there's been a lot of good information shared tonight. We're right at the tail end of everything. The last two items, 7 and 8, were really related to inspections of the offices, the facility inspection. Is that something that anyone would like to spend some extra time on right now?
This is Dr. Freed. I'd like to make a quick comment about facility inspections. My group represents a little over 20% of the moderate sedation providers in the state, and we've never been asked to be to do an inspection on any facilities. Never been asked to be involved in any of the, sedation input. And frankly, after having this conversation with the current committee, I am scared to death to have them or anybody that they know do an inspection on my facility. So, I would like rules proposed to have an independent CRNA committee potentially come in and do an inspection on my facility. I prefer not to have the current ACC committee do any inspection on my facility. Thank you.
Scott, this is Ed Lynch.
Ed, please.
Yeah, couple things with respect to some of the comments that I made earlier. My thought is that I understand where you're saying we need to have a team approach. I understand and I agree with we need to have certain equipment available and have that ready when a patient is being sedated. And I think that we can look at that as being different with a moderate sedation from either a CRNA or whoever else it might be. versus a and general anesthesia. And I think a lot of the discussion with respect to that has been and general anesthesia. I'm talking moderate sedation. Why can't, instead of me having to go through and do all of the inspections, all of the CE training, I'm not going to override Kara. If she comes in my office and says this patient needs ABC, I'm not going to override her. She does it way more than me. So whether I have a moderate permit or not is irrelevant, because I'm not going to override her. I've dealt with them, the CRAs, enough to know they know their stuff. But what I'm saying is, okay, instead of me having to have all of that equipment in my office, and Tim having to have all of that in his office, and everybody else, why can't we have it as an agreement? Okay, Carrie, you're coming in my office. You provide A, B, and C. I'll provide D because it's too big or too cumbersome or too whatever to be able to move easily. And you're only going to be doing moderate sedation. And if it goes to a deeper, or if we need or want deep and general anesthesia, then we have a whole different category of things. Then I have a moderate sedation. Okay, fine. But if we're only doing moderate sedations, and yes, I know they can go beyond that. I get all of that. But what I'm saying is, if we want to truly make it safe and make it more available, why can't we do something on that order where it's an agreement between the general dentist and the CRNA or whoever the provider is, and that agreement has to be approved by the board, whether it's I have everything or Kara brings everything in when she comes in. I don't care which one it is, and it doesn't matter as long as that is there when the patient is sedated and that it's safe for the patient.
God, I would like
Thank
to
you.
comment
And-
on
Who's that?
Jerem Heaton with ASDA.
Yeah, please.
We just went through this in Texas, provider inspections versus facility inspections. And can you imagine if I wanted to do anesthesia in a place, and hey, today I went into a place and I had an inspection. They inspected all my equipment. They looked at my anesthesia machines. They looked at my monitors. They looked at all, my crash carts that I bring in. And they did the inspection, and then the next day I went next door. The same people came out. They looked at the same facility, all my equipment, all my monitors. And then the next day I went out and they looked at all my equipment and all my monitors. And then the next day, and I did this for what, 200 offices in Texas. That's very, very onerous for the general anesthesia provider to go do that. So what we did in Texas is they inspected the provider got his inspection, and then he's allowed a portability permit. So they have, that's based on their, the board came out, looked at all my stuff, did all my emergency protocols. I have to have all my stuff updated I have to keep logs of the equipment and the things that go into my practice. And then that follows you from office to office. That inspection takes place when you get your permit, and then obviously again when if you want to do it every 5 years, fine. If you want to do it based on complaints, that's a great plan too. But you inspect the provider, make sure they have their stuff. There's an affidavits that they'll have it, and you can, and that takes away, that ensures they have their stuff that they have when they go into offices, and then they can, then that improves access to care. It improves the way for general anesthesia to be provided for these patients that so need it throughout whatever state that you're in. But to have monitors and inspections of every facility that you go in is hard from a board perspective to get that many people out there. Two, it's very redundant because you're looking at the same equipment over and over and over again. And to have equipment that a dentist provides that doesn't even know exactly what that equipment is, I think is also, that leads to less safety. So I think that these inspections are needed. Let's inspect the provider. Let's inspect their equipment. That's fine. to do it over and over and over again and make sure it's in every office is, I think, is very onerous to the provider and limits care and is not good for access to care.
Yeah, so that's an interesting model and some good feedback, and appreciated that information from your perspective, and having been involved in providing care and seeing the challenges that come along with doing it in a way that doesn't create unnecessary hurdles, but does address safety, and that will be taken into consideration. I would just say as we finish up that I've enjoyed listening and learning tonight and hearing a lot of different perspectives, and those will be taken into account by the committee. But just know that the committee doesn't make policy. Certainly, it's influential in making recommendations to the board, but the board does that, and I do know I bristled. And I don't need to make it difficult, but Dr. Fried, the people that are on this committee have given of their time just volunteering. They were asked to provide their services. They do it selflessly and of their time and their resources. And the sort of accusations of limiting practice and selfish motivations are very disingenuous. But I appreciate everyone participating and sharing and being willing to listen, and I have every faith that together we'll digest all this and we'll make some good recommendations to the board, and the board will and this isn't going to be a fast process. We're going to take our time, and there'll be lots of opportunity for feedback until we come up with what's right for South Dakota. Brittany, do you want to comment?
I just want to think, as we finish up, I know Dr. Croft had mentioned he wanted to make just a couple more points relative to his feedback. If Dr. Croft, would you be able to make those in like a minute or less?
Yes, I like brevity. So the couple of comments, the team model, I don't think I'm opposed to a team model as is utilized in an oral surgeon's office, for example. I do think that whatever the board considers as the minimum safe team model ought to be allowable in any location. So if that's one provider and two assistants, or two providers and two assistants, it needs to be across the board. So that's just just a level of parity that should be considered, however the board decides to go forward with that. The other comment is that and I'll be very brief on this, as relates to dentist anesthesiologists, oftentimes it's easy for a dental board to forget that we are not physicians, we are not nurses, we are dentists. And we provide anesthesia in a similar manner to nurses and anesthesiologists, but we are dentists providing dental procedures, the dental anesthesiology procedures. And so a lot of times boards will attempt to regulate non-dentist anesthesia providers in a certain way so that they can manage what we do if CRNAs or physician anesthesiologists come in and work, and then they lump dentist anesthesiologists in, and it becomes very problematic. And so my hope is that the board would recognize this, and that any time that a regulation is put into place meant to regulate the practice of nursing anesthesia or anesthesia provided by physicians, non-dentists, that be so stipulated that these non-dentist anesthesia providers being brought in are regulated in X, Y, and Z manner, and that dentist anesthesiologists be appropriately regulated, as any other dentist would be. So those are my comments on that.
Yep. Thank you very much. I might just end quickly with a thank you to everyone. We appreciate your feedback. I think the goal of all of this was to obtain that feedback as we continue these discussions. Certainly understand that in any type of regulation, kind of figuring out how to form these boxes in a way that can help ensure patient protection, that is not overly burdensome, but again, ensures patient protection. It's a tall order sometimes, and it's difficult, and we understand that these impact your practices on a daily basis, and that is very personal. And so we appreciate you engaging in this conversation. We intend to continue this conversation going forward. And Dr. Freed, I know we've run over here. I'm happy to follow up with you on that course.
Yeah, absolutely, Brittany. You know, and to respond to Dr. Van Dam's comment about being disingenuous, I know several sedation providers that would be more than happy to help out the ACC committee. I also think there should be fair representation on the committee based on ratios. There are 19 deep sedation providers in South Dakota. There are 27 moderates. I think there should be a 2-to-3 ratio with 2 CRNAs on the committee. And any further policies going forward, it should be approved with CRNAs on board. Thanks, Brittany. Appreciate it.
Nope, I appreciate that. And we are always looking for anesthesia inspectors across the board. So if there is anyone interested in serving in that role, there is a protocol that we must follow, but we are always looking for volunteers to give of their time. So that's relative to the inspectors as well.
And the anesthesia inspectors that have gone out have uniformly received positive feedback. There's effort to try to minimize conflicts when there's conflicts with individual providers. There's a lot of effort to do this with respect for the providers. There is absolutely, it's unfounded to imagine that there's specialists, that have it in for moderate sedation providers or that are making their life difficult. That's not been ever borne out with interactions and the way that inspections are provided. There's not been any negative feedback. These are people that give of their time, and we'd love to have a larger group of inspectors, and a very diverse group of inspectors. And but the criticism of the inspections, the people that have gone into offices have done so with kindness and with safety in mind, and have had a lot of positive impact on helping providers who are coming up to speed, to get up to speed, to see deficiencies, and to make it a good place to provide anesthesia. And anything to the contrary or that would criticize how that has been conducted in the state is disingenuous and not knowledgeable of how it goes, and of how the experience is received and perceived by those that are getting helped.
So I might just mention, as we move forward, obviously there's a lot of information to digest based on the feedback today. I think the intent is to take some time to kind of sort through that. We'll certainly, as noted before, this is recorded, so we'll post that so folks can take a look at it and refer back if necessary. Then the intent is to continue this discussion. And so I would envision in the future that there will be another opportunity to provide feedback, whether that's at the anesthesia committee level or at the board level. Again, wanting to ensure that we have an opportunity to kind of process through all that we had today. So thank you very much for the feedback. As this moves forward, we have a list of everybody that was participating today. We also have our regular stakeholders that we are communicating with, and we will do our best to continue to and to over communicate, if nothing else, so that everyone's on the same page. Thank you.
Thank you, Brittany.
I'd like to point out that this board is, I think, quite unique in the fact that we are so interested in having as much comment as we can receive, and we realize that it takes more time and might be contentious, but our feeling is that will put us in a position that we are best to make the best decisions possible. Thank you, everybody, for your input tonight, and have a Merry Christmas.
Thank you.